2-4 video, Ramsay Hunt syndrome, mechanism and the audiovestibular limb, vestibular physician. Welcome back, focused clinical learners, to part 2 of our Deep Dive Explainer series. It is absolutely fantastic to have you here. Today, we're transitioning right from the broader epidemiology straight into the fascinating microscopic mechanics of this disease.
Now, I want to start by posing a really common clinical paradox to all the neuro-otologists and vestibular physicians watching. You've probably thought about this. Why exactly does Ramsay Hunt recover so much worse than Bell's palsy? And maybe even more weirdly, why on earth can debilitating vertigo arrive before the face even begins to droop? It's a mystery we face all the time in the clinic. Well, today, we're going to crack it wide open using pure, unadulterated mechanism.
Okay, let's dive into this. Our roadmap for today is pretty straightforward. First, the compartment palsy. Second, the audiovestibular limb. And third, vasculopathy and polyneuropathy.
So kicking things off with Section 1, the compartment palsy, specifically VZV reactivation in the geniculate ganglia.
This right here brilliantly illustrates the entire disease process. Just look at this pathophysiological cascade. It all starts when latent varicella-zoster virus is triggered, usually by immunosenescence, some kind of physiological stress, or immunosuppression. From there, you can actually trace the cascade right down. It goes from geniculate ganglionitis directly to facial nerve edema, and then it ultimately branches out. It'll either cause a lower motor neuron facial paralysis or spread to cranial nerve 8, hitting the patient with severe audiovestibular symptoms. Honestly, it's a remarkably clear flowchart of a really devastating pathology.
Now, what's incredibly interesting here is exactly where this all starts. It happens right at the first genu of the facial nerve within the temporal bone. You'll notice point number 1, the geniculate ganglion. This is the sensory ganglion of the nervus intermedius. And it's the exact, precise location where VZV sets up its lifelong latency after that primary childhood chickenpox infection we all know about. It literally just sits there, dormant, waiting for a trigger.
And when it does reactivate, you don't just get a little bit of mild irritation, you get full-blown geniculate ganglionitis. I really want to emphasize the mechanistic severity of this microscopic damage. Look at these histological characteristics, hemorrhagic necrosis, and dense lymphocytic infiltration. I mean, we're not talking about simple swelling here. We are talking about profound tissue necrosis happening right inside the nerve.
Let's move along and see how this builds, topodiagnostically tracing the deficits outward along the facial nerve to infer the exact level of the lesion. So if the inflammation hits at the geniculate ganglion, the patient is going to experience deep otalgia and vesicular eruptions in Hunt's zone. Moving distally, if the greater petrosal nerve gets involved, it reduces reflex tearing, causing a dry eye. Hit the nerve to the stapedius, they'll complain of hyperacusis. And if it travels all the way down to the chorda tympani, you're going to see dysgeusia, that altered sense of taste, along with a dry mouth. It's basically a perfect diagnostic map.
So the crucial contrast we need to make is right here. In Bell's palsy, you're generally dealing with a predominantly edematous neuropathy, right? But in Ramsay Hunt syndrome, that hemorrhagic necrosis and inflammatory edema happen inside the rigid, non-distensible fallopian canal. There's nowhere for the swelling to go. It massively raises endoneurial pressure and completely compromises the vasa nervorum, the blood supply to the nerve itself. This causes severe compression ischemia, demyelination, and actual axonal loss. It's a true compartment injury. And that mechanistically explains exactly why RHS has such a poor prognosis compared to Bell's.
Moving right along to Section 2, the audiovestibular limb. Let's look at the direct impact on the inner ear.
So how does a facial nerve problem cause such severe dizziness and hearing loss? Well, there are 2 distinct, non-exclusive routes here. The first is contiguous inflammatory spread. Basically, the inflammation just jumps across the tiny gap separating the facial and vestibulocochlear nerves inside the internal auditory canal. But the second route is arguably way more important: primary VZV reactivation directly within the spiral and vestibular ganglia themselves. Studies have actually found VZDNA right in these ganglia, and they noted that the viral load directly correlates with the severity of the cochleovestibular presentation.
I absolutely love this quote from the source material. Cochleovestibular symptoms in RHS are not merely spillover from the facial nerve. They often reflect direct VZV reactivation. This is a massive clinical pearl, and it directly answers our opening hook. Because the virus can wake up directly in the vestibular and spiral ganglia, it perfectly explains why severe vertigo and sensory neural hearing loss can completely dominate the clinical picture or even arrive days before the face ever begins to droop.
Okay, on to Section 3, vasculopathy and polyneuropathy. Let's zoom out and look at the wider disease.
You see, the virus doesn't always just stay confined to cranial nerves 7 and 8.
Look at Hunt's chain of ganglia. This is this beautifully interconnected network where inflammation can spread, either by contiguity or via a shared vascular supply. If the inflammation travels through this chain down to the petrous or jugular ganglia, your patient might present with a complex polyneuropathy. We're talking dysphagia, hoarseness, or a depressed gag reflex. This is exactly why you must always explicitly examine those lower cranial nerves.
And the unifying mechanism behind a lot of this wider damage? It's VZV vasculopathy. The varicella-zoster virus has a marked tropism, like a real preference for infecting vascular endothelium. This creates an underlying substrate that compounds the mechanical nerve compression we talked about with direct vascular injury. It damages both the large and small vessels, heavily compounding the ischemic component of that compartment injury.
This brings us to a critical warning that every single clinician needs to keep top of mind. In immunocompromised patients, this VZV vasculopathy is usually not subclinical. It can actually extend into a multifocal arteriopathy, causing an actual ischemic or hemorrhagic stroke. Let me say that again, a stroke. If an RHS patient starts developing focal neurological deficits beyond the cranial nerves, you must actively look for central involvement. It elevates the clinical stakes significantly and obviously completely changes your entire management plan.
Let's quickly synthesize this whole anatomical journey into 3 really powerful, memorable clinical takeaways for your practice. 1. The facial palsy is a rigid ischemic compartment injury. It's definitely not just simple edema. 2. The inner ear symptoms actually stem from direct ganglionic VZV reactivation, which is exactly why that vertigo can strike first. And 3. VZ vasculopathy is the unifying substrate that connects all these serious wider complications.
And that brings us to the end of our mechanistic deep dive. Next up, in Part 3, Diagnosis and Investigations, we're going to turn all this mechanistic knowledge into a really sharp testing strategy to help resolve that challenging overlap with Bell's palsy. But think about it. If the mechanism of Ramsay Hunt is so distinctively severe, are our current diagnostic criteria actually catching it early enough to save the nerve? We will answer that next time. Thank you for watching this series. To explore more similar topics regarding dizziness, vertigo, and imbalance, and to access clinician and patient resource materials, visit AustralianDizzinessClinics.com. Please subscribe and leave a rating.